Hi, I'm Tracy Donegan, founder of Gentle Birth. In the following video, you're going to get to meet obstetrician extraordinaire Dr. Natalie Elphinstone, who has been pioneering the gentle mother-led cesarean in Australia. Her protocols and guidelines are being adopted around the world as more parents literally take birth into their own hands. Hope you enjoy it.
Hi everyone, we're just waiting on Dr. Elphinstone to join us. There you are. How are you?
I am great, and call me Natalie.
Natalie, lovely to meet you. We've kind of been conversing on over Instagram the last couple of days. What's the weather like in Melbourne this morning?
In sunny Australia. Well, it is summertime here. Today hasn't been too hot though, but we're so looking forward. Bring on the hot weather, I say. I cannot wait for. We live near the beach, so I'm definitely looking forward to the warm weather to really hit. And it hasn't really yet, but we're just starting to get the hints of it. I'm super excited.
Well, I'm visiting family in Ireland at the moment, a long way from Texas, but back to my roots. But it's, yeah, as you can see, the sun is coming up in the attic this morning, but it's gorgeous, but it's chilly. But thank you so much for joining me today. I'm really, really excited to talk to you and for you to share your thoughts on that video, on the work that you're doing, and really why it's so important, because I think it's a magical video. I really think this is an opportunity to get the word out there for more parents to have this opportunity available to them as often as possible. So tell us a bit about yourself, background, and why this matters.
Well, I have to say I was absolutely blown away by the response to this video. I mean, I'm super excited about it. I'm super passionate about this option that we're giving people, but I wasn't expecting such an immense response, and it's been really overwhelming. But I'm really excited because I'm so passionate about exactly what you said, about inspiring people to advocate for themselves, that if this is something that they want to do, then there shouldn't be a reason why you can't do it, or there shouldn't be many reasons why you can't do it. But let me start off by saying, yeah, I'm Natalie. I'm not an obstetrician and gynecologist, but obstetrics is definitely my passion and my heart. And I work down in Australia. I've trained and worked only here, so I don't unfortunately have that experience of being able to say what the US system is like or other systems. So when I talk today, I'm definitely going to be talking from my own experience and what I know to be true where I work. But maternal-assisted cesareans, right? What a concept. Now, I'm not the first person to do this. I'm not the only person to do this. I'm not about to claim that I'm an expert in it, but I have started doing this, and it has been a revelation about how important this has been to so many people. So the women that do it are loving it, absolutely loving it. I have not had a bad word said so far. I've never had one woman who's afterwards gone, you know what, I wish I didn't do it that way. I'm excited to spread the word. And this video was just one way, of course, of me sort of showing what it actually looks like. And as I said, really blown away by the response. So I guess getting back to that original question, so I've started exploring this option myself only really in more recent times. And what was really interesting about it, so a lot of the questions that I've already had people say was, how can I make this happen? And my first response to that is, so me as an obstetrician, why did I start doing this? I did this because somebody asked me. One of my patients asked me if she could do it. And instead of having the response, so the easy response for me could have been to say, well, we don't do this at this hospital. We've never done this at this hospital. I've never seen it done, and it's just not the way we do things. I mean, that's the easy answer. But the other part of me said, but why not? Why can't we do that? And how amazing would that be? And so luckily she gave me at least enough warning. She asked me this, I think when she was maybe sort of 28 weeks pregnant or so. So I had enough time to then work on how we could actually make this happen. And there's red tape to jump through, and there was policies to write, and there was meetings that I had to present this to get the approval of the hierarchy And let me tell you that that was an interesting little story in itself. But ultimately, I got the go-ahead to do this for the first time. And of course, in great irony, this woman who asked me and who really instigated this ability to do it at the hospital didn't get to have it done, unfortunately, when she had an emergency cesarean instead. However, it did then mean that we now, we had this policy now written and we had people on board to do it. And so then when we finally did get to do it the first time, tentatively, understanding that there could have been things that maybe wouldn't go right, but it could not have been more perfect. It went without a hitch. And I posted that video on my Instagram as well. So you can backtrack and have a look at that one. And I've said, this is my first one. And, you know, it was amazing. And so it's just blown out from there because, of course, the minute I start talking about this or people can see that I now do it, I have had, of course, more and more patients ask me if they can do it. And now I can say, yes, let's do it. And as I said, I've never had a bad word about it so far.
And how is it being received now in the hospital where you practice? Is it having a knock-on effect for other obstetricians to kind of tentatively step into this as well?
Yeah, I'd tell you what's been really interesting is also the knock-on effect it's actually just had for everybody, like everybody in the theatre, in the operating theatre. So let me tell you, one of the first ones, I think like, so number 3 or something that I did, and the scrub nurse who I had with me, so the nurse who's there being the one who hands me the instruments, you know, like on the shows when it says, nurse, hand me that scalpel stat, which I've never said, by the way. But she's the one who hands me the stuff. She is a very experienced nurse. She tells me she's been working in this field for 30 years or more. And so she's probably done more cesareans than I have. And we're doing this maternal-assisted cesarean. And the mother pulls out the baby and, you know, the mother's crying and the dad's crying. And everybody's just having this little moment. And I look around and my scrub nurse is bawling, silently crying these tears. And so I say to her afterwards, like, are you okay? What happened? And she said, you know, I've been doing this for 30 years. A cesarean to me sometimes just feels like another operation. It's not that special. It's a bit cold. It's a surgery, whatever, but there's a baby, hurrah. And I didn't understand what this maternal-assisted Caesar was, and I didn't understand why people would want to do that. And then I saw it. And then I understood why this was such an important thing for these people and how special it was. And then she tells me the very next week that I saw her, she's got her son is expecting a baby. And she said, I've told them to ask for this. And I went, so she's now one of my loudest advocates. So she's told everybody in the theatre, you've got to see this thing. It's amazing.
Yeah.
And she's just one of many people who's really been inspired by this. And so, yeah, it's catching on. It's definitely catching on. So this is all happening at my private hospital where, you know, let's be honest, it's a little bit easier to do what you want, so to speak. But at the public hospital that I also work at, very quickly after I sort of showed these videos to like all of the midwives in charge, who were so excited about this idea, and it's already gone up the pipelines, and I've already had the, you know, powers that be ask me for the policy that I wrote for my private hospital, so that we can hopefully get it happening in the public hospital as well. So it's definitely catching on in my area. And that's why then, you know, this tonight, I'm hoping, of course, that we can help inspire it to catch on anywhere, everywhere. Why not?
I know. Are you prepared for the full inbox you're going to have this tomorrow morning when you wake up? I know it's late your time, for everyone that policy, because I think just so great to see that, you know, you've really done kind of, and I know others have done as well, but the fact that you're on here, you have done the groundwork, you have the documents, because I think that's a big part of it. Is sometimes there's a little bit of, yeah, we can consider it, but go and do all the research and pull together, you know, the protocols and everything. I think the fact that you know, it's kind of maternal-assisted cesarean in a box kind of thing. You can give us this, solution that it's not going to take years and years for hospitals to adopt this, because I know there's quite a bit of resistance in some areas of change, and change is hard for a lot of people. And I'm sure you're well aware that a change in practice, and even like a change in evidence, the length of time it can take, even with the most gold standard evidence, that it can often take, I don't know, I think it's an average of 15 years for a new practice to be adopted. But so how long would you say it took, kind of from start to finish, for you for the powers that be to agree that yes, we're going to do a trial and let's see how this goes?
I think you're going to be really, really surprised at the answer, because everything that you've just said is entirely true. It took me 3 months. That was it.
Great.
It was super easy. I mean, I know I say, I had to do those things, but because I'm not the first person to do a maternal assisted cesarean. So let me backtrack. So when my patient asked me for the very first time, can we do this? The first thing that I then did in response to that, for me, was actually set up a meeting straight with the CEO of my hospital, which I know not everybody necessarily has the ability to do, but I certainly took advantage of my position. I'm on the chair of, I'm the chair of the obstetrics committee, these sorts of things. So I set up a meeting with the CEO, and I said, what does it take to start a new practice in the hospital? And she told me the answers. It was, write a policy so that there is clear guidelines that we can follow. And then you have to present it at this meeting, you have to present it at that meeting, and you have to get the approval from these people. And so the first thing I did then was say, okay, well, I'm not the first person to do this maternal assisted cesarean, so what else is already out there? And we had other private hospitals in our network who already had a policy, so that was easy. I grabbed theirs, I adjusted it, I expanded it. So actually, when this first lady asked me if she could do Caesar, she didn't actually ask me if she could have a maternal assisted cesarean. She asked me if she could have a paternal assisted cesarean. So she wanted her partner, her husband, the father of the baby, to be the one to come in and help pull out the baby. And there wasn't a policy for that as far as I can see, but certainly very easy to tweak the maternal assisted cesarean to include that possibility as well. So I tweaked the policy. I presented it first at the obstetric committee meeting, where it really interestingly is where I actually met some of my strongest opponents. I was not expecting that, but I think it's because it shakes the way we've always done things. It shakes the system, and that, especially for perhaps our more experienced obstetricians who have been doing this job for years and years and years, and so consider themselves to be, king of all knowledge of how this works. This is something quite foreign, and this is definitely new and unfamiliar territory. And so they didn't want to actually have anything to do with it. And that's fine. So I'm not asking, when I present this to them, I'm not saying, so everybody should offer this. I'm saying now we have a policy, so now we can do that if you want to. And so it is still definitely true that there are still obstetricians around that don't want to do it for whatever that reason is. There are anaesthetists that don't want to be involved in this for whatever their reason is as well. There's pediatricians that don't want to be involved in it, and that's okay. But it's small baby steps.
Yes.
And as this snowballs, and as people can see why it's important, because I think part of it is they don't get it. Because I understand when I explain to somebody, and same with the patients themselves, if I explain to somebody, especially somebody non-medical, so the mother's going to reach down into her open abdomen and pull out her baby, I know what that sounds like. I know that it can sound like that's a very weird idea, and why would anybody want to do that? But I think people who maybe are thinking that way don't understand why this is such a powerful thing for the women who do want it. It is such a powerful thing for the women who, I'll tell you what, it's really powerful. It's really powerful for the women who have had maybe their first baby that has ended up with an emergency cesarean, and they've been really quite traumatized by that process because it snowballed. It got out of their hands. They weren't in control. They were frightened. They were anxious, and it happens the way that they weren't expecting it to happen, and they didn't plan for this, and that's been really quite hard for them to come to terms with it. And now they're pregnant again. And so, of course, they're thinking about how is the delivery of this baby going to go? And people in that situation are often really, really keen to advocate for themselves to have exactly what they want.
Yeah. And
sometimes the thing that they want is to have what they were hoping the first time, which was maybe, this vaginal delivery where they were empowered, where they felt important, where they felt the love and the joy, and they got to be involved, and they got what they expected, that wonderful moment where you get to have this immediate pull up your baby and put it on your chest and have that skin to skin and have that emotional moment. And they didn't get it in the emergency cesarean, and now they want it this time. But maybe they are thinking that a cesarean might be a safer option for them or a better option for them. But they still want it to be as close to that experience that they'd hoped to have maybe the first time. And for those women in particular, this is so powerful for them because it's a healing experience. Yes. As well. And geez, it makes me cry sometimes even just thinking about it, because their faces when this happens, it's amazing. It's amazing to be able to be in that room and see this instant restorative power of birth, which is what it always should be, and it doesn't always get to be. And now we have a chance of giving it back to them. And man, that's powerful. And when you see it, it's powerful. So the next thing that we're doing is, now that we've been doing these maternal-assisted cesareans for a long time now, I've just had the deputy CEO come to me and say, we need to now present some of these videos to all of the people who said, why would you want to do that? Because as soon as they see it, they will understand why it's important. Sorry about that.
No, it's, I'm here. Keep it. But it is about giving as much power back to those parents. It really is. It's so important. Is there, before we jump into the questions that we received, is there any, because one of the questions that came up was from a mom who had contacted me, and she'd had a cesarean, an emergency cesarean for a labor that didn't progress. And she said, well, I am considering a repeat cesarean this time, if I was to go for VBAC, and again, if I didn't progress, would I be a candidate? So what would be your criteria for, is it only for planned cesareans, or if it was, a non-emergency, like an unexpected, wasn't an emergency situation, what's kind of the criteria, I guess, that for yourself?
It's a really good question. So definitely at the moment, the way that it stands, or the way that the policy that I've got written at my hospital is that, number one, it has to be an elective cesarean. But, when we've written the policy, of course, this is written just the way we wanted it to be written, not because it's based on any real evidence or rules. The reason why we've currently said that it needs to be an elective cesarean is because of the idea that it takes preparation to do. And I mean that both before the event and on the day. So what I do with all of my women or partners who are planning on doing a maternal-assisted cesarean is that I need to talk them through exactly what that's going to look like on the day. So it's going to look like, if it's a maternal-assisted cesarean, it's going to look like the mother doing a proper surgical scrub, first of all. So that takes 5 minutes. to do. And this is, of course, because one thing that's really important to say is that at the end of the day, this is still a surgical procedure that we're doing. So we definitely need to not be putting the mother at any undue risks. So we don't want to increase the risk of having an infection, for example, or the risk of a hemorrhage or the risk of anything. So we still definitely need to keep in mind that it is a surgical procedure and understand the importance of that. So the mother will do a proper surgical scrub, first of all, and that takes a full 5 minutes to do. We gown and glove her the way a surgeon would be gowned and gloved. So there's a process to that, and you kind of have to learn that, or you have to understand how that's going to work. You have to understand what those rules of sterility are. So once you are scrubbed and gowned and gloved, you can't touch anything that's not sterile. And that also includes, of course, her partner or her birth support person. He or she can't touch now the woman who is scrubbed as well. And that's really, really hard. That's probably, actually, this is probably one of the hardest things of it, is that not letting the partner now touch her, or at least not in the areas where she's scrubbed. So you can touch her face, her hair, and that's what I encourage them to do. And so we need to talk through that process, and they need to understand that process. And then, yeah, on that day, it takes that extra time. And it's not a lot of time, but it takes extra time. In our policy, we've talked about allocating extra theatre time for it. We've talked about allocating extra nurses for it, so that there is somebody that's specifically watching her at all times to make sure she maintains sterility, those sorts of things. So at the moment, we've said only for true elective cesareans. That's just at my hospital. But I think that, so now, for example, I've got, say, 1 or 2 anaesthetists that I've really done the vast majority of my maternal-assisted cesareans with. And so they're very familiar now with the process. My scrub nurses are familiar with the process. The paediatricians are familiar. The midwives are familiar. And so I think it wouldn't be a far cry to now say, if we were in a semi-emergency cesarean situation, where, meaning it hasn't been planned before today, but we don't have to do anything in a rush, there's probably no reason why that can't happen. At the moment, I'm not wanting to rock the boat, because I definitely don't want
baby steps. Let's get this
baby steps. Exactly.
Because yeah, I can see maybe in a couple of years' time that, you know, part of the, you know, antenatal education is you know, that, and we're talking about this in antenatal education, that if you're, you know, this is available at your hospital, this is, or you know, in the classes in your hospital, that, you know, this may be an option, and being able to talk about it beforehand. And so if it is an option for, depending on the circumstances, that it's not something that's been discussed on the way down to the theatre.
Exactly. And so I think that's where the main problem lies, is exactly that. So that conversation that I have with people, and in fact, I often even do a literal mock scenario, put this gown and gloves on and get them to lie down on the bed, have a doll that they can pretend to pull out, you know, where they're then going to put it, what it actually looks like. So that sometimes it's the logistics of, how do I get a baby out of my abdomen? I've never done that before. Do I lift up? Do I lift forward? What, you know, these sorts of things. And yeah, you can't kind of rush through that conversation. So that's why at the moment we're sort of saying elective cesarean only, but let's definitely evolve. I mean, that's what it's all about. It's about evolving with time, and as new changes need to happen.
Yeah, great. So a couple of the questions that came in this week. One question was on cord clamping. So is delayed cord clamping an option with these circumstances?
Yeah, in fact, I think it's even easier to do delayed cord clamping at a maternal assisted cesarean, because of course the whole idea is that the mother gets to hold the baby. So assuming that there's at least enough length in the cord, you know, the baby's going to go straight onto her chest. And let me take a back step. So certainly at both of the hospitals that I work at, public and private, in either emergency cesareans or elective cesareans or anywhere in between, it is our policy to do delayed cord clamping. We're actually aiming to do delayed cord clamping at every cesarean for at least 1 minute, so at least 60 seconds.
Yeah.
And so that's our standard anyway. But at a maternal assisted cesarean, it's even easier to, of course, then do it for longer, because I'll tell you, the mother doesn't want to give up the baby after 60 seconds. The mother wants to just hold the baby. And in fact, that's part of it as well, that maybe we don't even need to take the baby off the mum at all. Again, tweaking. So, because I think, maybe probably the follow-up question is about that direct skin to skin as well, because both of those things we know are really important. In fact, we know that delayed cord clamping for at least 60 seconds and direct skin to skin contact between the mum and the baby is not only a nice thing to do, but it's evidence-based, it's scientifically proven to be beneficial for a whole bunch of reasons. So why can't we do that as cesarean? Why does that only have to be at a vaginal birth? And the answer is there is no reason. It definitely can be at a cesarean. Some of the concerns that people have, or what the opponents say, is things like you're going to increase your hemorrhage rates of mum, or you're going to increase your neonatal morbidity because maybe the babies are going to get cold. But of course, the whole idea of doing things like skin to skin is to help thermoregulate the babies as well. So it's actually a good reason to do skin to skin, to help improve the temperature of the baby. So yeah, I absolutely do delay the cord clamping. I always say, look, everything though is a proviso. Everything meaning, if at any point in time, and this is the spiel I give to my mothers and their partners, if at any time me as the obstetrician or the surgeon is not happy to continue with the maternal assisted cesarean because of some surgical complication that we're having, if the anaesthetist is not happy for us to go ahead with the maternal assisted because of some problem with monitoring her vitals or some complication that they're having, if the pediatrician is not happy because they are worried about the baby's status and they need to get in there, or of course if she breaks sterility, at any point, even when we've got everything planned, if any one of us says actually we can't do this anymore, that they have to be accepting of that. And so we definitely have that chat ahead of time as well, and so far so good. It hasn't actually happened. It's potentially bound to happen at some point in time, but that's part of the conversation, so we understand that that's a possibility too. At the end of the day, I always tell them, at the end of the day though, we're definitely still going to have your baby. So no matter whether or not it's a maternal assisted cesarean or we're doing it the standard way, you still get a baby at the end of it. But of course, let's make it as nice an experience as they possibly can.
Yeah, because one thing that's over the years, what I've heard from parents is when they're having a planned cesarean, was it just for the staff, and you mentioned how you have the nurse was quite moved by the experience. It's an everyday occurrence for staff, but for you, you're about to become a mom. You're about to meet your baby, and it's so when the staff were walking around talking about what was on TV last night and not missing that reverence of the moment. So I think this is really going to bring back that for everyone in the room to see that this might be a normal day at work for me, but this is like this family will never forget this day for themselves. So just following on from the delayed cord clamping or optimal cord clamping questions that I've heard from people who might be more resistant to introducing this option would be, no, the theatre is too cold, we can't do this. So when you talk to this about, again, we're back to thermoregulation, but do you change is the temperature change in the theatre?
Yeah, we do. So there are always typically very easy solutions to this. So yes, number one, we do turn up the temperature in the theatre. And the only people that suffer for that is me or the people that are scrubbed. I tell you, once you're in scrubs, plus you've got a surgical gown on, you've got 2 pairs of gloves, you've got a mask, you've got the eyewear, you've got a cap on, you're underneath the bright surgical lights, and the room temperature is set to about sort of 24 degrees. I am sweating, I can tell you that, but that's okay because it's not about me, it's about them. And so very happy to make sure that I'm hydrated and get through that situation. So we turn up the temperature in the theatre. And then of course the other thing that we do, and I know that perhaps a lot of the videos when I'm putting them on Instagram and I'm doing a reel, so, you know, you've got to keep it to a minute's time, is that I cut out a lot of this stuff. But we instantly sort of put a drape over the baby as well, or very quickly put a drape over the baby too, and to help dry it off, and of course to help keep it warm as well. And yes, going direct skin to skin now with the baby, because we know that that's the most important temperature the baby can be anyway. So there are solutions to this. There are always solutions. We just have to look for them. We'd have to be willing to change our practice. Just because something has always been done some way doesn't mean that it has to continue being that way.
Yeah.
Let's change.
Yeah, absolutely. And so following on from the temperature change, then another question then as well, if we change the temperature, then, you know, might increase the risk of infections. So and again, you've already talked about the sterile field and parents, you know, understanding what's happening, but parents will also have an antibiotic right before the cesarean. Is that common practice in Australia as well? Yeah.
Yeah, correct. So it's always our standard. It's part of our guidelines for surgical antibiotic prophylaxis that are cesarean. They do get, unless they decline, a shot of antibiotics. It's normally only a single shot of antibiotics that they need. Again, I always say to people, because that's definitely a common reason for why people are concerned about this, is that apart from the fact that the woman herself is doing all of the same sort of surgical preparation that I am, she's actually not putting her hands into her open abdomen. She's really only really touching the baby, in fact, and the baby's already out of her. So when we're doing it, of course, and as you've seen in the videos, I still do the same kind of cesarean as I do, meaning baby's coming out head first. So I get its head out, I get its shoulders out, I get its arms out, and then the mother can literally just reach down, put her hands underneath its arms, and lift it up. So she's really only touching the baby anyway. She's not actually even putting her hands into the wound. So of course, the mum continues to be more at risk from what I'm doing to her than she is about what she's doing to herself. And we definitely don't have any evidence that I'm aware of or that I can find that talks about this increasing any kind of maternal or neonatal risk. Although, to be fair, I think that's mainly because there hasn't been any research into that. I'd really actually love somebody to do research into this, about the importance of it, about what the maternal outcomes are, both physically and psychologically, because I think that would be amazing evidence. It's not out there yet as far as I can see, but it does mean that I get to say there's no evidence that it increases maternal infection rate.
Yeah. So again, I have a lot of followers, you know, from around the world, and a lot of the comments that I've had are, you know, this looks amazing, and I want to make sure I didn't lose you. That this
I'm still here. Yeah.
Okay, so this is I know I'm going to have a repeat cesarean, and I want this. How can parents self-advocate for this option in their community?
Well, I think, you know, my story of how it happened for me is enough evidence to say you just have to ask. I think that's the first thing that you do. And even if you perhaps know or think that you're going to get the answer that says, well, we don't do this here at this hospital, or I've never done that, or I've never seen that done, or I've never heard of it. But if that obstetrician keeps having people ask, they're going to have to think about it, aren't they? They're going to have to see that this is what people want, and make them see that it is getting done in other places. And so I think that's step one. So even if perhaps you still get the answer that says, no, we can't do it, you're starting to make that step in the right direction. And so that's what I tell my people at the public hospital. So as I said, at my public hospital, we don't have a policy for this yet, but I get people all of the time that says, can I ask? And I say, yes, ask. Because the more people who ask, the more the powers that be will see that this is what people want. Yeah. So that's the first step. And of course, then I think the second step is that when the person then says, no, you can't have that, you say, but why? and why not? And having the answer that says, well, we don't have a policy for that, is not a good answer. And you say, why can't we make a policy for that? Because there's no answer to that. What?
With a policy that's already been written. Yeah.
Because there are policies that exist. So let's just get one of their policies. Somebody can tweak it. It won't take very much work.
Yes.
Why can't you get a policy for that?
Yeah. It's interesting, again, depending on where parents are living. So in Ireland, we have a public health system, but there's also there's private obstetrics as well, but we don't have private hospitals anymore. So there's, and I know it is happening to a small extent, depending on the obstetrician around the country. But when I talk to my the parents in the US, where it's very much a for-profit hospitals and a huge involvement in insurance, and because what I found when I was teaching antenatal classes in a hospital where they didn't have nitrous, so, or we call it gas in air, wasn't available yet. And I kept at every single class, I said, nitrous is available in the hospital down the street. So you need to keep asking, why isn't it available here? Because parents were starting to vote with their wallet and take their dollars down the street to where they had more options. So I think, as again, consumer involvement, and keep asking the question why. And I think the more people that keep asking, it'll happen. It might not happen, unfortunately, at this point, but I think parents can also, if they have an option to go to a hospital that offers this option, and it's really unfortunate if you have already got a relationship built up with an obstetrician and you're used to the way this hospital does things, to make that it's a big deal to change hospitals or change obstetricians during pregnancy. So it's not something that's easy to do. But if this is important to families, if it's meaningful for them, I think it's something just to kind of consider. Maybe, or maybe not this go around, but if they were to go through this again and have another baby, that it's another option for them. But definitely, keep asking the question, and don't take no for an answer. Just keep asking. But I have to say, we eventually did get the nitrous. It took about a year to get it, but there were some grumblings from staff that the parents kept coming to their antenatal appointments and kept asking for it, and they kept saying to me, "Don't keep telling them to come asking for it." I'm like, "I'm just going to tell them to keep asking, because it's a good option for them, and there's no reason why it shouldn't be available for them."
Exactly.
What I know, I've taken up a huge amount of your time tonight. I know how busy you are. I've seen you. I can't even imagine what your 24 hours in your life is, and especially this time of year. I really appreciate you spending the time with us today. Do you have any final words? What would you like to say to those parents and obstetricians that are watching, and midwives that are watching as well?
Yeah, I think, thank you everybody for coming and joining in. I'm so excited that people all around the world are keen to have this as an option. And I as I said, I'll speak for the Australian experience. I can't speak for the rest of the world's experience. I know that I am in a privileged position where we have the ability to ask our healthcare providers for things and hope and expect that they'll come to the party. And I know that that's not the case all around the world. But let's continue to be that voice to ask for change. I think, it would be really, really great to see actual research come out. I think, as I said, if we have research that talks about how this improves outcomes for mothers, and maybe from that mental health perspective, if we could show that it did things like reduce postpartum depression, reduce our, birth trauma statistics, that would be powerful, just talking to that, as you say, that bottom dollar part of it, which, makes the healthcare system go round, as horrible as that is. you know, that would be a really powerful thing. So let's keep on talking about it. Let's make it so well known that this is an acceptable practice in other places of the world. So even if you're in a place of the world where it doesn't happen and you feel like it can't ever happen, keep showing them how it does happen here. So it happens in Australia. I do it here in Australia. Show them the videos of how it works, because it's actually not that hard. It shouldn't actually cost very much more extra money. I think the only extra cost is involved in an extra pair of gloves and gown for the mum that we wouldn't otherwise have, but that's essentially it. There's no other equipment that we need. So it's not going to cost very much more. And if it saves money, that's excellent. But let's also talk about how it saves our mental health system, and it saves our babies from having to go to the nursery because they're getting that skin to skin and that delayed cord clamping. You know, let's look at those things. That would be really, really excellent. But let's get the word out there. Let's spread the word about how this is a thing. This is definitely a thing. Yeah.
And hopefully it won't be a thing for much longer, and it'll be the norm and expect. Yeah, absolutely. Thank you so much for joining me. And we are going to chat again early in the new year on the Gentle Birth podcast, and we'll I'm sure there's lots more to talk about. Did you want to share your Instagram and where people can find you?
Yeah, absolutely. So the main place definitely to find me is on my Instagram. So that's at Dr. Natalie Elphinstone, which is all one word. That's doctor with a DR, and then Natalie, Natalie, and Elphinstone is Elphinstone. It's really long, sorry.
I'll type it.
You'll have a link, I'm sure. Follow me there, because that's definitely my mainstay of where, you know, I post my videos, and I post, you know, and the vaginal birth that I do as well, because it's not just about cesareans, it's about empowering all women to have the best version of the birth that they can possibly have, whatever that looks like for them, because we know that that is different for everybody as well. Yeah. So let's make it the best version for them as it possibly can be. And yeah, let's change the world.
Thank you. That was wonderful. And yeah, we will talk again soon. And I look forward to sharing lots more of your videos.
Yay. Thank you so much for having me.
Thank you. Take care. Bye.
See you later. Bye.